We're looking forward to a review and some questions related to acid base. Thank you very much.
Oh, thank you very much for inviting me, for having me here. As I said, I'm by far not the expert. I'm just retired from the EDIC committee. So I have to say that when I planned this lecture, I looked at EDIC question database, and I thought, well, I just did not look at the test tomorrow. Did not want to go into it, not to reveal anything. So I don't know what the question look like tomorrow. But what I did, I just went through the question on acid base and AKI and got inspired. And I was thinking, well, how can I help you to pass successfully through these questions if I only have 20 minutes for it? And I simply planned my lecture according to this. And I just said, well, let's have a look at how can we distinguish combined disorders in acid-base pattern. And that is because some questions were bread and butter, simple, straightforward answer, DKA and these things. But those who can perhaps distinguish between very good candidate and excellent ones were about combined disorders. So I'll start with a type K question. When you've got an elderly man scheduled for real laparotomy for leaky anastomosis, he is apparently sick, but his blood gases look okay, actually. It looks almost normal. And now the questions are whether he is severe, whether there is no severe acid-base disorder, whether there is high anion gap metabolic acidosis or circulating ion, or eventually if there is a hypochlorhydremic alkalosis, perhaps correcting it, or hypoalbuminemic alkalosis. So that's kind of a question which may occur, and I would now focus my talk to it. Well, first of all, sick people have sick values, and the acidosis or alkalosis is a process rather than a deviation of pH, which we call acidemia or alkalemia. So if the pH is normal, it does not necessarily mean that there is no acid-base disorder, because there could be more than one disorders going into opposite directions and offsetting each other. So how to recognize it? We, again, well, very basic stuff is, and we are all used to looking at blood gases according to approach, well, developed in the 50s in Copenhagen, when simply they judge on acid-base status according to status of a bicarbonate buffer, when they simply look at the ratio between bicarbonate and carbon dioxide, which determines pH. And this is true, this is law of chemistry. But there are some problems with this. First problems was elegantly solved in the late 50s. And this problem was that simply if you have got an isolated deviation of CO2, perhaps, suggesting a neat respiratory disorder without any metabolic component, then bicarbonate still goes high if CO2 goes high because of the shifts in this equation. So CO2 and bicarbonate are not independent on each other, so they had to introduce the concept of standard bicarbonate or base excess. And these values tell you what's the metabolic component cleared of any influence of CO2 deviation. Standard bicarbonate is telling you what the bicarbonate would be if the PCO2 of the patient would be in the middle of normal range, 5.33. Base excess does the same, but it's just the it's very similar. So, well, and that's why you've got sometimes these values on a blood gas strip. So actual bicarbonate is the one which is calculated directly from Hasselbalch equation. Just PCO2 is measured, so is the pH, and actual bicarbonate is derived from this equation. And standard bicarbonate goes more, and it's mathematically corrected to PCO2 of middle normal value. Base excess, well, it's the definition. The original concept is that they really bubbled the gas with PCO2 of 5.3 through a test tube with heparinized blood and then measured pH and titrated it. Now it's all done mathematically, but concept is still the same. According to bufferation capacity, there is a difference between blood and extracellular fluid base excess, but for clinical purposes, there is no point of distinguishing between these two because I haven't found any clinical condition when this may be important. So the problem one is solved by introducing the concept of standard bicarbonate and base excess. That's fine. The thing is that, well, the body reacts to any disturbance to bicarbonate buffer by changing the other system. And in America, in Boston, they developed 6 different equations which were empirically derived to show you what degree of compensation is appropriate to a given simple disorder. These rules are sometimes difficult to remember, but one of them is worth to remember because it can really help you, as I'm going to demonstrate in a moment. And this is the rule for appropriateness of partial pressure of CO2 in case there is a metabolic acidosis. And it's just actual bicarbonate divided by 5 plus 1 kilopascal. In order to demonstrate it, it's just if you have had a case with a 21-year-old girl with presumed DKA seen in emergency room with actual bicarbonate 7 millimoles per liter, so profound acidosis. So if you have, and imagine these situations, A, B, C, these situations differ according to level of PCO2. So if you apply Boston rule, then you've got predicted PCO2 as 2.3, which is the appropriate compensation. And that's exactly what is seen in situation A. So if there is a situation A, we say, okay, that's just appropriate compensation for the EKA, and this lady needs insulin, fluids, and treatment in medical HDQ or even on a diabetic ward. That's fine. Situation B, however, without knowing Boston rule, could be easily overlooked. And this means that this lady has got a combined disorder because PCO2 is too low for the condition, which means that there is a component of respiratory alkalosis on top of this metabolic acidosis. And it needs some attention. You have to think about it. She may just be anxious and hyperventilating for it. However, she can also have another diagnosis. It may not be a DKA. It can be, you know, a typical picture of salicylate poisoning. Or she could be pregnant, and it needs, you know, this pattern requires attention. Situation C, it's a combined metabolic and respiratory alkalosis. Metabolic and respiratory acidosis. And despite CO2 is still lower than the normal limit, it's by far too high under the circumstances of profound acidosis, and this suggests a impeding respiratory failure. I would like to have such a lady on intensive care unit because if it comes to intubation, this can be extremely tricky, as you all probably know. So we are now at the stage when this was a demonstration how you apply the rule of Boston to judge and how to distinguish superposed respiratory disorders. Now, well, the classical diagnostic algorithm in metabolic disorders is just to look at the chloride and calculate anion gap. That's something you probably all know, that if anion gap is normal, then it's the chloride which displaces bicarbonate from the anion column. And then we have to ask questions, where is the bicarbonate being lost from? Is it the kidney? Well, it could be renal tubular acidosis. Is it the gastrointestinal tract? Or has the patient had too much saline? On the other hand, if there is an elevated anion gap, chloride usually remains normal, and we have to look for the circulating ion, which can be a classical either lactate ketones or inorganic acid in AKI, or it could be some anion from an unknown substance. That's all fine, but that's just, and that's the way how you could look at it at this stage, just identify the basic type of the disorder, then look at the clinical context or eventually calculate an ion gap and assess whether there is a appropriate compensation. That's all fine, but that's not enough. Because the problem with this is that there could be disorders offsetting each other, and even the picture when looking at the bicarbonate buffer alone could be normal. So the answer is use the electroneutrality approach. It's been developed by Peter Stewart, and it simply uses a very simple rule that because we are not electric fish, all the sum of anions and cations in all body fluid must be equal, and therefore it can be calculated. I can just demonstrate and these guys were fascinated by computers and equations, and it sometimes creates a myth that this approach is just too difficult. Let me show you that it isn't, and that it can be very useful, and you can even use mental arithmetics easily to gain a lot from it. So you can assume that because there are strong ions like sodium, potassium, and chloride, they are always ionized in the solution, and therefore, their concentration is relatively fixed, okay? So if I simplify it to a difference between sodium and chloride, you can imagine that the sodium and chloride create a gap among them, okay? Let's call this gap strong ion difference. And this gap defines a space which is in principle only occupied by two entities. This space is shared by bicarbonate and negative charges on albumin and perhaps phosphate, but let's forget about it. So in principle, and then concentration of bicarbonate together with PCO2 define pH in patients' plasma or blood. And if you look at acid-base like this, it can be really eye-opening, because if the difference between sodium and chloride is higher, then because the negative charges on albumin and phosphate are relatively fixed, it means that there must be more bicarbonate. So this explains why low chloride, or being more precise, higher difference between sodium and chloride causes alkalosis, and vice versa. If the space between sodium and chloride is narrow because the charges on albumin are fixed, then it means that the concentration of bicarbonate is lower and there is a metabolic acidosis. So what I would recommend is that if you have got a difficult acid base, the first step you do is just look at sodium chloride difference, and if it's much lower than 35, then you have hyperchloridemic acidosis, regardless of pH or other values, but the process is there. On the other hand, if it's much higher than 40, then there is a hypochloremic alkalosis as a process. The next step is just look at albumin level. If you have it, or if you don't have it, just assume what the albumin level of this patient might be. And you know that the only number to remember is that roughly 10 grams of albumin per liter is 3 millimoles of negative charges, okay? And if you know it, then you can say, right, if the albumin is too low, within given space between sodium and chloride, this leaves more space for bicarbonate, and this explains metabolic alkalosis due to hypoalbuminemia. And then the last step is look at whether negative charges on albumin plus bicarbonate match the difference between sodium and chloride, because if they don't, there must be a circulating ion. So let me demonstrate this concept. So strong ion difference can be estimated or approximated by looking at sodium minus chloride. Charges on weak acid, 3 millimoles per liter per 10 grams of albumin per liter, and PCO2 is the same, okay? So that's the method. And this explained why low albumin can cause alkalosis, simply leaving more space for bicarbonate, and why hyperchloridemia causes acidosis, okay? So if I could recommend, and there are many approaches, and I will show some of them later on, it's just one of many ways how to simplify the rule of electroneutrality and use it in clinical practice. Just dissect the patient's blood into calculation of sodium chloride difference and eventual detecting hypochlorhydremic alkalosis or hyperchloridemic acidosis. Look at measured or estimated albumin level and calculate the charges on albumin and look whether these values fit, okay? And if they don't, there is a circulating ion. So if we use this approach to our case, you can see that sodium chloride difference is okay, so it's probably no chloride disturbance. You can detect metabolic alkalosis here because of the low albumin, and you can estimate that if there was no other disorder, base excess would be between 7 and 9. And then if you fill the gap, if you calculated the 37 sodium chloride difference to be filled with negative charges, you realize that there is 11 millimoles missing. So this 11 millimoles represent a space for potentially circulating an ion. And indeed, in such a sick patient, it is probably lactate. So here are the answers, which are self-evident. And there are other approaches. I won't go into details. And if you are, somebody asked me when I was having this lecture on the other course, well, do I rather use base excess partitioning or David Story's simplified method? It does not matter. If you have an electroneutrality-based approach, it doesn't matter whether you use corrected chloride, base excess partitioning, or Gilfix method or whatever, but it just look at the electroneutrality somehow, okay? I found these methods a bit mathematically too complex. I can't calculate 142 divided by sodium. It's beyond my mathematical capabilities, so I don't like corrected chloride for entirely this reason, but it works equally well. So I would recommend then, when you look at the case during your EDIC exam, EDIC 1 or EDIC 2, just think of the clinical context and what acid-base abnormality do you expect. And if it's there, you are done, okay? And if it sounds, if it looks dodgy or suspicious, or if you have a sick patient with normal value, just use this intellectual approach by first looking at sodium chloride difference, which would, regardless of pH or base excess, detect abnormalities of chloride. Then look at the charges of albumin, then put them together, and this would detect circulating anion, okay? So other tips and tricks, just to conclude my talk, learn about the use of osmolar gap. Just repeat what osmolar gap is, and that if you have got low molecular alcohol is the most common occurrence in the EDIC, then the difference between measured and calculated osmolarity can detect it, usually together with elevation of anion gap. because these alcohols are metabolized. I came across about difficult questions on pyroglutamic acid acidosis. No one really knew it, but it appeared in EDIC, and it's a combination of oxacillin and paracetamol in the vignette, and high anion gap can point it out. If you have got a patient with short bowel and undetected iron and normal measured lactate, think of D-lactic acidosis, salicylate and ethylene glycol. And there are some clues. So, take-home messages. When doing EDIC acid-base cases, be suspicious with normal gases and a sick patient. Please use Boston rule to detect superposed respiratory abnormality on top of metabolic one. And please, for difficult cases, use some of the simplified acid-base method based on electroneutrality to dissect the case a bit more. And I hope I have answered some of the questions, and I hope you will find this lecture a bit helpful tomorrow. Just to conclude, if you succeed, please make sure we are doing EDIC 2 preparatory courses in 6 to 8 February in New Delhi and 24th to 25 March in Brussels. So if you want to go there, book the date now. Thank you very much for your attention.